All right, everyone. Welcome to tonight's national webinar series here. We have Dr. Jeff Gerson. He's going to be doing myths and misperceptions in posterior segment disease. I think you guys out there probably realize that Jeff is a friend of OEC. He's a friend of myself. We have traveled together, we have lectured together, and that's one of the nice things about being in the lecture community. You form this brotherhood that's out there. So you're going to have an amazing lecture tonight in retina. Jeff is a graduate of the Indiana University School of Optometry. I know Jeff did a residency at a VA in low vision and ocular disease, but he currently practices in a private practice in collaboration with an MD, where Jeff is allowed to do his favorite thing, and that's posterior segment disease and retina. So with that being said, Jeff, thanks for being here tonight. Thanks for doing this for OEC, and thanks for sharing your expertise in retina. I'm looking forward to it, and I'm sure the audience is also. Thank you.
Awesome. Thank you, Greg. Thanks everyone for being here. By the way, I thought it was cute, Greg, that when you're saying to, monitor the bandwidth, I just imagine my teenage son, me going to him and asking him to stop playing video games, which is why I go to my office when I do these things because I know that the bandwidth issue at home, I'm going to lose out every time. So welcome everybody. I'm glad you're here. As Greg said, the title of the talk is Myths and Misperceptions in Posterior Segment Disease. And what I would tell you from an introduction, what's important to me is people know that I'm in a private practice. And the reason I think that's what's important is because anytime I do a talk like this, I put myself in your seat, in your shoes. What would I want to hear? What's practical? What can I use in the office tomorrow? Because just like you guys, I see patients that come in to get their eyes checked. It just so happens that a fair number of people have posterior segment disease, actually, just like your practice, whether you realize it or not. But again, what's important to me is to talk about things that are interesting, practical, and applicable. So that's my goal tonight is to talk about things in that fashion and get you thinking and potentially tomorrow doing things just a little bit differently than maybe you would have today. Quick disclosure, I've been involved with a number of different industry companies. All relevant relationships have been mitigated, which means that as we go through this talk, hopefully you will not recognize any bias of any kind. So I start my talks with a conclusion because right now everyone's paying attention and I don't know how long that's going to last, hopefully the full time. But if not, I want to start with the conclusion, the take home points. And number one is that as ODs, we are the front line of most retinal pathology. It's not retina specialists. Retina specialists get patients that we send to them. They start in your chair. You are the front line. There's treatments available today that weren't just a few short years ago, and they essentially all work better with timely intervention. Now, some of those treatments may be administered by an ophthalmologist, some may be by you, but either way, the sooner we intervene, the better people do. Again, and to the third point, some treatments are by us, and some are MD-driven ones. But some of the things that you as an OD can do are just as good or better than the MD-driven treatments. Now, quick note, the advantage of a grand rounds course kind of like this is being able to touch multiple topics and jump around a little bit, which kind of fits my personality. The disadvantage is that for each of the topics we talk about tonight, I could go on for 2 hours with each individual topic because there's so much there. But I want to try to touch on a number of different topics, so it'll be somewhat rapid fire. And so I just wanted to kind of disclose that, give you that so that you know that ahead of time. All right, so let's talk first, just real quick, prevalence and relevance. If something is prevalent enough, it is relevant. It isn't rare if it's in your chair. Everyone has heard that. But let's focus on the more common. And I want to talk about things tonight that are a little bit more prevalent, therefore more likely to be more relevant. Now, I think we all know, but it's worth saying that age can sway what you see in your office, but we all see common conditions, right? So when you ask me what are the most common back of the eye things that we see, the big three that I think of are AMD, glaucoma, and diabetic retinopathy. Which one of these do you think is the most common? If we were in person, I'd be picking on a couple of you and have you actually answer the question. I won't do that yet because that's one of my polling questions we'll get to very shortly. But bottom line is you should be seeing more AMD then you do glaucoma and more AMD than actually all your glaucoma plus your diabetic retinopathy patients. So AMD should be something that we're seeing in our offices on a fairly regular basis. So I just said it. So let's see if you're paying attention. Here's polling question number one. In your practice, which do you see the most of? People with diabetic retinopathy, B, people with glaucoma, C, people with macular degeneration, or D, people with vascular occlusive disease. So statistics and just general prevalence numbers would tell us what the answer here should be. And when I do this in person, there's always somebody that raises their hand and says, my practice is different. And my kind of smart aleck response to that is always, no, it's not. Your patient mix is likely the same as everybody else's. You may not be noticing it. So,
Yeah,
Greg,
the answers are rolling in here.
they're
So
rolling in. All right. So
yep.
again, this is
So
how we know you're interacting and how we make it synchronous.
yep. Let me
And so I
just
know,
check the I don't think it will mess up. I'll check the chat box. Nothing's in there. So a lot of times we just check to make sure that there's a good time to answer questions.
yep.
The looks like the trend is in and people have responded. So I'll display it so they
All
can
right.
see it.
Let's see.
And we have 15% going with diabetic retinopathy, glaucoma is 9%. Macular degeneration is the winner at 74%, 0% with a zero with the vascular occlusive disease.
Perfect. And you know that's what I would expect is that the vast majority would say AMD, not just because I just said that as the answer, but because that's what statistics would tell us that that is the most common of these conditions in most people's practices. Now, if you have a much younger practice and maybe a very urban setting with poor overall socioeconomic status, then I can understand if diabetic retinopathy was your answer. But for the vast majority, the right answer is going to be macular degeneration. All right, so let's talk about some myths and misperceptions about macular degeneration. So, first myth, AMD is not common. It really is. I can tell you from testing I've done in my office for a study that I did. It never actually got published, but it was an IRB approved study that up to 40% of my patients above age 60 have some level of macular degeneration. So, certainly it's a myth that it's not common. It is a myth that nothing can be done to slow the progression of dry AMD. That's actually true not just for up to intermediate, it's also true for advanced dry AMD. It's a myth that wet is better than GA or that GA is better than wet. It's kind of like which type of diabetes is better, type 1 or type 2? The answer is the same as which type of advanced AMD is better, GA or wet. The answer is neither. You don't want either. Another misperception, treatment for GA will stop progression. Tons of commercials on TV and consumer magazines and other locations about treatments for geographic atrophy. The misperception that many patients will get is if they get it treated, it will stop it. That is not true. Another myth is that supplements for AMD are all about lutein and zeaxanthin. Those are probably the workhorses, but it's not just all about them. So, again, up to 40% of your patients have AMD. There's well-proven nutritional intervention and newly FDA-cleared light-based treatment. Neither wet nor dry is good. Progression of GA can be slowed, not stopped or reversed. And emerging signs to all sorts of diets, supplements that can be beneficial. So, intermediate AMD, I think what we need to realize is oftentimes goes undiagnosed. Now, when I say intermediate dry AMD, those are people that have any large drusen and or age-related pigmentary changes. So more than mild, not yet advanced. This was a study that was published in 2017. And what the people that ran this study did is they went to eye care providers, both MDs and ODs, said, we want you to examine these patients age 60 and above. And all you got to do is let us know, do they have AMD, yes or no? And take a fundus photo and send it to us because we're going to grade you. Now, two things I think are really important about that. Number one, if you tell me all I got to do is answer one question and you're watching me, I'm going to try pretty hard. Number two, if I'm taking a picture that I'm sending you to grade me, I'm going to look at that picture and again, I'm going to try pretty hard. So this is a pretty unrealistic scenario, right? You would think that the doctors would do a great job. However, if you take all the patients that the doctor said did not have AMD, 1/4 of them actually had macular degeneration. Of those, 30% had large drusen. How do you miss that? 24% almost had pigmentary changes. Um, 25% of the time, AMD is missed. When that is the only thing you're looking at, you're being graded and you have pictures to look at. So for any of you that say, well, I don't see that much AMD, we're all probably seeing about 25% more than we think we are. So this is pretty scary. By the way, the statistics were the same in the OD practices and the MD practices. This is an eye care problem, that there's way more macular degeneration than what is getting identified. So let me ask you a question. When you go to your office tomorrow and you do an exam and you're doing your clinical exam, what's kind of the minimum findings that you would say it takes for someone to qualify as having AMD? So what do you need to see for you to say, oh yeah, this person has macular degeneration? So Greg, if somebody sends something in, if you could let me know if we're getting any interaction. But what I would tell you is that the most common answer I'll get is drusen. And that's a pretty good answer, although people are allowed to have small drusen. Small drusen are 63 microns. 63 microns is half the size of the central retinal vein as it comes out of the optic nerve. You can have small drusen. It can just be age-related change and not AMD. But in general, most people with AMD have drusen. The other common answer I get is pigmentary changes, age-related pigmentary changes, and that is true. Sometimes people will say, well, a patient has to have a decrease in vision. That's not true. You can have wet AMD. You can have geographic atrophy. You can have both of those and still have 20/20 vision. So we cannot use visual acuity to tell us who does or who does not have macular degeneration. Now, by the way, once you find macular degeneration, it's our responsibility to communicate that diagnosis with our patients, talk to them about it so that they know what's going on and so they understand what we have to say and why we want them to do what we want them to do, whether it's a change in their clinical follow-up schedule, whether it's lifestyle modifications, whether it's nutritional supplementation, which I know I agree with Greg that I'm a huge, huge advocate for nutritional intervention supplementation. We need to explain what's going on so that people will follow through with the treatment objectives of what they really need. By the way, it's not always easy to talk about macular degeneration, but I would tell you that if you have a diagnosis of very early or mild AMD, that's almost good news. And the reason that's good news is we're finding something at a stage which we can do something about it to be proactive, to be preventative. Now, if you find someone with more advanced AMD or wet AMD, that's not really good news, but it may not be terrible news if you find it while their vision's still good. So it's all relative. And the way you deliver the message dictates how your patient perceives the message. So this is a tricky one that we all probably need to work on. Now, what's really interesting is as primary eye care professionals, we see the vast majority of early and intermediate macular degeneration. A very small percent, only 14%, are seen by retina specialists, and the rest are seen by optometric community and or general ophthalmologists. So there's likely about 500,000 intermediate AMD patients that are being taken care of in our offices. So this is really an optometric condition. This is a condition for which we lead the care for. But unfortunately, we don't diagnose AMD early enough. What I showed you from the study that I just presented, that how so many patients are undiagnosed, even when that's the only thing that's being looked for. There's been published studies that talk about the same thing. There's a published study by an anterior segment MD that used dark adaptation to diagnose AMD and found very high prevalence. This is really an important issue, that it is way more prevalent than what we think. We just need to be looking, and we need to be looking probably a little bit harder than maybe what we have done historically. But who cares? Who cares if we diagnose it early enough? Well, because the earlier we find it, we start talking to people, we can make it easier to talk to people about AMD, important lifestyle. And I'm already mentioning MPOD, macular pigment optical density. And even if you're not measuring macular pigment optical density or not measuring carotenoids in any fashion, that's okay, but it's an important metric that we can use to help gauge risk and actually help gauge compliance with nutritional intervention that we prescribe for our patients. And you'll hear me say that nutritional intervention that we prescribe. I know you don't have to actually write a prescription for nutritional intervention, but if you make it sound like a prescription, you're way more likely to have people listen to you versus just saying, oh, yeah, you should probably take a vitamin. That's not the idea. It needs to be prescribed. We need to be doctors and give out prescriptions. If we're going to talk about nutritional intervention, something that I think we can't not talk about, and again, I could easily talk about this for a full hour, but don't worry, promise I won't. AREDS 2. What did AREDS 2 tell us? Because we had long-standing information we knew about AREDS 1, but AREDS 2. AREDS 2 told us that lutein and zeaxanthin are helpful. They were not in AREDS 1. That reduction of zinc was not helpful. It wasn't hurtful either, but it wasn't helpful. Omega-3 in AREDS 2 didn't help. Beta carotene was not helpful. And mesozeaxanthin was not tested. So we can't say from AREDS 2 whether mesozeaxanthin is important or not. But again, that's from that one study. But what the study tells us is the bottom line is if we supplement the right patients, so those with intermediate dry AMD, with an AREDS 2 supplement, we can prevent conversion about a third of the time. But about 2/3 of the time, people will still convert, even with the best known of interventions. So even when you do all the right things, some people still have a poor outcome. How can we gauge who might be more likely to have a poor outcome in macular degeneration? And by poor outcome, I mean develop advanced AMD, and ultimately have vision deterioration. So there's a AREDS simple scale. This is one of the things we learned from the AREDS clinical trial, and it's a way we can look at our patients and gauge risk. And what we do, we look at each eye, and at each eye we look for any large drusen, we look for any age-related pigmentary changes. Either one of those, you get a point. So each eye is worth 0 to 2 points. So between the two eyes, 0 to 4 points. This game is like golf, not bowling. You want a low score because what we see is if you have 0 points, your risk of conversion to advanced AMD in 5 years is less than 1%. If you have 4 points, your 5-year risk is about 43% and your 10-year risk is about 70%. I love this scale because I love to be able to tell patients about really low risk because it helps to bring it eases anxiety, it makes them feel better if they have AMD, but I can tell them that they're at very low risk. So for example, if someone only has intermediate sized drusen and no pigmentary changes, that's 0 points. Their 5-year risk is basically 0. So you're telling someone they have AMD, we're going to be proactive, but the risk over the next 5 years of a bad outcome, that's how I say it, is essentially 0. So it's important to know scales like this. AREDS 2 had a 10-year follow-up, and what the 10-year follow-up told us is basically the same as the 5-year, that adding in the lutein and zeaxanthin is important to reduce the progression to late AMD. Now, incidentally, it's actually adding in the lutein and zeaxanthin and taking out the beta carotene. Both is worse than just the lutein and zeaxanthin. So with beta carotene, number one, people are more likely to progress. Number two, they're twice as likely to die. So there's really no place for beta carotene in an AMD related supplement. Now, by the way, I just shared with you the AREDS simple scale. It's been recently updated about a year ago to also look at what are called reticular pseudodrusen. What are reticular pseudodrusen? Well, when you're looking fundoscopically in that image labeled A, it's the little dots that you see that look like very discrete little drusen. And that's what I'm using my pointer to point at. These are the reticular pseudodrusen, and here are the actual drusen, okay? And here we see them on OCT. And so what we see on OCT is the reticular pseudodrusen, these white arrows, they sit above the RPE, whereas drusen sit below it. So drusen push up on RPE, reticular pseudodrusen sit on top of RPE. It's important because reticular pseudodrusen basically double or more the risk of progression to advanced AMD. So we need to look not just for drusen, but also for reticular pseudodrusen. All right, polling question number two. When discussing nutritional supplements with patients, do you A, avoid the topic, B, make very specific recommendations for what to go and buy, C, sell products in my office, or D, tell people to just go and get an eye vitamin? I didn't
All
put
right.
E for something else, but while we're doing that, Greg, any questions or comments coming in yet?
The polling question is open. I see people responding, which is good. Questions? No, it's been quiet. It's been a quiet evening. So remember, anyone, you
Right.
have any questions, put them in the chat box. I can monitor those. Polling question is open, and looking kind of curious to see what this outcome is. So
Me too. It's interesting because it can be a polarizing question for how people handle this topic. Because some people are very uncomfortable with different facets of the different answers here. And so it's always interesting to me when I talk to colleagues and find out what's your strategy for how you do this. And quite frankly, I've heard all four of these from colleagues.
yeah, I think it's tough because I think, I've been kind of studying the naturopathic ways over the last kind of 6 to 8 years. And, every optometry school is allopathic, meaning opposite cure. So I'm an
Yeah.
allopathic doctor, obviously. I mean, I do antibiotics for styes, and if you got inflammation, steroid, and if they have a high pressure, we lower it. So opposites cure, that's allopathic. But, functional medicine, naturopathic is kind of getting to the root cause, like diabetes is more insulin resistant, and they were probably insulin resistant. And maybe we should focus on less carbs and more protein and so on and so forth. But, it's a tough conversation because we were never really taught it, and we try and plug these allopathic methods into a naturopathic way, and it just kind of messes up they're two separate languages at times, and we start kind of maybe confusing them and overlapping them. So I think that's the
Yeah.
biggest thing
Yeah.
that
Well, even
happens.
even if they're the same language, they're completely different schools of thought, right?
Right.
So
Yeah.
to your point, that's what can make it really difficult. Can make it really difficult.
All right. So we got a nice trend here. Looks like everyone's kind of weighed in. So avoid the topic is 0, which is good to hear.
Good.
B is your winner at make very specific recommendations at 88%. And then
Wow.
sell products in the office is 9, and 3% tell people just go get a vitamin.
Got it. It's about what I would expect. I would have thought there'd be a few more that sell products in the office. Um, But that's a topic that people are become very passionate about. And I understand why people would sell supplements in your office. Some would say, well, it's for the financial gain. And not too many people get rich from selling supplements in the office. It could be a nice source of revenue. I'm not saying that it's not. To me, the big deal though is then you absolutely control the quality because once people are out of your office and they're going to the store, it doesn't matter, what you wrote down, what you gave them as a sample. It's up to them to buy it at the store, right? And if you look at the aisles, the vitamin aisle in a store, there's so many, it's dizzying. And you may have an exact product you wanted to get. You may prescribe it, make it very clear. They go get something else, and who knows what it is. So selling from your office guarantees quality. It guarantees the product. And so I absolutely understand why people do that. And kind of, I guess, kind of piggybacking on Greg, what you were just saying on how we treat things and things more naturopathically. Mediterranean diet has been shown over and over and over again to be beneficial for lots of different disease sources or disease types. But there's been some really good recent literature talking about Mediterranean diet very specifically in macular degeneration. I have here a reference to a study that where Mediterranean diet decreased the risk of advancing to advanced AMD by 40%. Emily Chu, who was principal investigator of AREDS 1 and AREDS 2 studies, now also advocates for Mediterranean diet and says, and I put here in quotes, that it's never too early or too late to adopt a healthy diet. Which, I mean, it sounds like well, duh. But like anything else in science, you have to prove it, right? To be able to actually say it, you want to be able to say, well, we have proof of that. And so it doesn't matter at what stage of macular degeneration, or as it turns out, diabetes or almost anything else, If you want to talk to someone about their diet and specifically about Mediterranean diet, it's never too early, it's never too late. This is a disease or a disease. This is a discussion that I wholeheartedly believe that we as optometrists should be having with our patients about the type of foods that they eat. What's in a Mediterranean diet? Now, to be totally honest with you, if somebody asks me what's in a Mediterranean diet, I tell them go Google it because, like you guys, I'm in private practice and I see 20 patients in a half day. I don't have enough time, unfortunately, to go over all the details. What I'll tell them is that, a Mediterranean diet probably has more fruits and vegetables and nuts and lean proteins. It's okay to have some whole grains. It's okay to have some alcohol. A lot of things that's important to eat in moderation, but generally very low in red meat and refined sugar, refined carbohydrates. Now, by the way, if somebody asks me which diet is better, Mediterranean or paleo or Atkins or something else, my answer is almost always yes, because anyone that's thinking about what they eat and making an effort to eat healthier is going to do better than the average American diet. I mentioned earlier lutein and zeaxanthin, they're not the only things that are important, but when it comes to AMD and diabetes, as it turns out, and memory, skin health, and cardiovascular health, lutein and zeaxanthin are really important. Spinach and kale are probably the best sources. You see how many milligrams per 100-gram serving. But very realistic sources are things like romaine lettuce and broccoli, and it takes three-ish servings a day, 3 to 4 servings a day to get enough to really be preventative of macular degeneration. By the way, I talk about fruits and vegetables, and an apple a day keeps anti-VEGF away. There's proof of that. However, apple juice or any other fruit juice, that's not the case. There was a study that showed that for people that consume 1 serving of juice a day, they increase their risk of developing advanced AMD by 21 times. That's not 21%. That's 2,100% by having 1 serving of fruit juice a day. But if you have less than one per day, then there's no association. So a glass of juice a day incurs incredible risk for advanced macular degeneration. How has this affected me? So when I go to conferences, and Greg, you see this all the time too. You go to conferences, if you're there, if you're the morning lecturer, for breakfast, there's always orange juice and there's always apple juice, and sometimes there's grapefruit juice. I always used to get a glass and have it half orange juice, half grapefruit juice. I avoid that like the plague now. I stay away from the juice. Now, people ask, well, what is it about the juice? Is it all the sugar without any of the fiber? It's probably at least some of that. Regardless of exactly why it is, fruit, good, whole fruit, good, fruit juice, not good. By the way, what's the leading source of fruit intake in this country? Orange juice. Some fairly new data. And I put stuff like this in because I had patients that heard about this. Melatonin supplementation in AMD, that melatonin supplementation may decrease the risk of development of or progression of macular degeneration. There was a US-based study and there was a study from China that both showed this. Neither one was very specific on the amounts of melatonin, so I guess more to be learned and discovered. But man, there's so much out there. There's so many different ways that we can potentially decrease risk. There was also a study that looked at curcumin or turmeric-based nutritional supplements. And it showed that this natural anti-inflammatory and antioxidant can decrease the risk of developing advanced macular degeneration. So if someone already has AMD, then you can almost cut in half the development of advanced GA, for example. For those without macular degeneration, you cut the risk of developing dry AMD by 77%. You cut the risk of GA by 89%. You cut the risk of wet AMD by 72%, and you cut the risk of blindness in less than half. So this is another super interesting one to me. We're starting to see more turmeric in different supplements that you might see. Smoking is bad. That's kind of the bottom line here. I shouldn't have to tell you that. We shouldn't have to tell our patients that. However, the reality is 90% of patients with AMD are never told to quit smoking, or at least that's what they say. And less than half of smokers know that smoking may be bad for their eyes. Who thinks smoking is good for anything, right? I'm just reporting you survey results. So it is super important, amongst other things, to talk about smoking with your AMD patients. So the five things that I talk to every AMD patient about are trying to have a healthier diet, which means more green leafy vegetables, less refined carbohydrates. I sniff and say either quit smoking or don't start smoking. I look at them and either say maintain a healthy body weight or consider losing some weight. Say try to be active. And what I tell people is you don't need to run marathons or pump iron, just do something. And then number five is I recommend a specific supplement for them depending on who they are, their stage of AMD. Now, I mentioned physical activity, and what I tell people is that you heard me. I literally say you don't need to run marathons or pump iron. There's a study that showed that if you walk 1 block per day, it cuts the risk of wet AMD in half. 1 block a day, you cut the risk in half. So it doesn't take much. Just do something. So I quoted myself there because I think that's actually a pretty good line. Because if you tell people they need to start exercising, they think they need to go join a gym, and they think they need to do this, they need to do that, it seems unobtainable, and they don't do it. Make it obtainable, make it easy. I think that's a really easy, practical thing that we can all start to do. If you're going to tell people try to start walking more, don't tell them, hey, you ought to try to get 10,000 steps. It's not going to happen. I work out a lot. I did a 40-minute kind of power walk right before doing this. I'm not at 10,000 steps for today, but I'm living a healthy lifestyle. So you tell someone that's not living a healthy lifestyle to walk 10,000 steps, what's the odds that it's going to happen? Slim to none. They're going to get frustrated and quit. So you don't need to run marathons or pump iron. Just do something. All right. So I love tech. I love gadgets. 4C Home is something that I use for my patients, and the cursor's on that here. 4C Home is something that we use for our patients with intermediate dry AMD. Scanley over here on the right, that is a home OCT. Yep, home OCT. That is FDA approved for people with wet macular degeneration receiving treatments to help retina specialists know when to treat based on patients' actual changes, and not just guessing. But this is what I use in my patient population fairly frequently for people with intermediate dry AMD. It works way better than an Amsler grid. People are way more likely to catch conversion to wet early and end up with good vision that allows them to continue to read and drive. And for most patients, it costs them zero. That's a pretty good deal. Can light help AMD? So, fairly newly approved or cleared by the FDA is a device for photobiomodulation using light to induce chemical reactions in biologic systems. In the study that got this device to be FDA cleared, almost 60% of eyes treated that had intermediate dry AMD gained more than 5 letters. On average, people gained 5.5 letters over 1 year. And almost 20% of people gain 2 lines of acuity. That's pretty incredible because if I look at my patients with intermediate dry AMD, the vast majority are already 20/20. And in this study, on average, they're gaining a whole line. That's pretty amazing. It also decreased the occurrence of geographic atrophy using very specific light stimulation out of the device that you see here on the upper right-hand corner. This is something that's done in office. It's not necessarily easy. It's easy to do because it's light, but what's not easy is it requires treatment 3 times a week for 3 weeks, 3 times a year. Now, each treatment takes approximately 8 minutes total. So it's quick and it's just light. It can't hurt you, but it's a lot of visits over the course of a year. This is something that it's not really mainstream yet because there's not enough doctors that have it. But I think that whether it's this device or something similar that's yet to come, I think this is going to become a very commonly performed treatment in optometric offices for our patients with intermediate dry AMD. So stay tuned for more about this, but I think this is something that I don't know if it's 5 years from now or when it is, that majority of us will be doing in our offices for our AMD patients. It's good for patients, it's good for the practice. Um, just to give you an idea with the currently available device, the initial capital investment somewhere around $68,000. Each treatment costs about $17.50 per eye. So that's $35 to treat both eyes. Simple math would show you that if you treat 20 patients for a year, you've paid for the device because of how much gets charged for doing it. And this is something that as optometrists, again, we can be doing in our offices. We have enough patients that we can be doing good for our patients and a ton of good for our practices financially. Wet AMD obviously is very treatable. I'll assume you all know this. Our job is to help prevent the need for the treatment in the first place through lifestyle interventions. Um, there haven't been any new drug approvals in the last 12 months other than biosimilars. There is a new drug device approval, which is a little implant that gets put in the eye and releases medication over a 6 month period of time. I get it, we don't do that, but our job is to know that treatments are available, have some idea of what they are so we can explain it to our patients when we refer them. Geographic atrophy is now treatable. There are two FDA approved medications for this. Um, I think this is a really important topic that I want to spend a couple minutes on. An important subset of macular degeneration, and for a couple of reasons. One, we think of GA being slowly progressive, similar to glaucoma, and it's not. GA progresses way faster than what we typically think of happening with glaucoma. So what's important to know is once somebody has any GA, 2/3 of people with GA are not able to drive within about 1.5 years. 40% of people, if they have a little bit of GA in both eyes, they lose 2 lines of letters in their better seeing eye within just over 2.5 years. And so it doesn't take a lot of time to lose a lot of function. What we also know is the older we get, the more likely we are to have geographic atrophy. For people in their 90s, almost more than 1 in 5, between 1 in 5 and 1 in 4, will have some geographic atrophy. What are the risk factors? It's essentially the same as for anything else related to macular degeneration because GA is a subset of macular degeneration. What are some of the things we can be looking for on OCT? And I just have some different examples here, and you see the different arrows pointing to the different lesions. Here's the point I would make here. GA is more common than you think. You need to be doing multimodal imaging to look for it. And I would tell you the best two ways to image are OCT, like you see here, and fundus autofluorescence. Those are going to be the two ways that you will be most likely to see geographic atrophy if you're going to catch it early. Now, I would tell you the least effective way for detecting or monitoring geographic atrophy is color fundus photography. This is an obvious case. You can't miss it here. But here you have a case that on the left, the color image, you might miss it. But on the right, in the fundus autofluorescence, where you have that dark circle, that's geographic atrophy. And then you see the OCT below, that's geographic atrophy. These are all the same patients. What gives away the geographic atrophy here is we're missing layers within the outer retina here. They're just gone. And what that does is it creates choroidal hypertransmission. You see the choroid much brighter here where there's the atrophy than what it is over here. And this next slide does a really nice job of showing that. So choroidal hypertransmission. So think of OCT as a light shining into the eye. Think of the outer retina photoreceptors, for example, as absorbing light. Well, when there's atrophy and those layers are gone, the light doesn't get absorbed, it keeps going through. And we're then able to image or see the choroid. And so for me, this is one of the easiest ways to identify even subtle GA. This is a dramatic case. None of us are going to miss this, but we need to use dramatic cases to make it easier for us to understand what we should be seeing in a much more subtle case. Here's a patient of mine, a GA case. What would you do? This is an 87-year-old male, 20/25 in the right eye, 20/40 in the left eye. Is this somebody that you refer to a retina specialist. So here we have color, we have autofluorescence, and we have OCT. So what if I tell you he was sent to retina and didn't want to go because the patient said it wasn't bad enough? Well, my response is, well, once you wait for it to get bad enough, there's no turning back. Kind of like glaucoma, right? So if you've heard Joe talk about glaucoma, I'm sure you've heard him say things like, the earlier you intervene, the more vision you save. It's the same thing here in geographic atrophy. If you wait for someone to lose vision, enough visual field in glaucoma, you can't get it back. You're going to have an unhappy patient. GA is the same way. Earlier referral, earlier treatment. Here's another patient scenario where we see color, then we see fundus autofluorescence, then we see OCT. 79-year-old female, very active. She came into me saying, I want to get my eyes checked before I move to Europe. I asked, why are you moving to Europe? Well, because my vision's already bad in the right eye, and the left eye is going to get just as bad. And I'm taking some very special vitamins, but I want to move to Europe because here in the US, public transportation isn't good enough. And once I'm legally blind, I still want to be able to get around. So I'm moving to somewhere in Europe with good public transportation. So she's moving to Europe because of she's worried about vision loss. This is someone that needs intervention. Unfortunately, she went to a retina specialist that at the time was not treating GA, and she said, "You know what? I think I'm going to leave it alone. My left eye's not bad enough to treat, so I'm not going to do anything." Man, if that's me, that is the wrong answer for sure. Um, I think this is someone that needs to get treated. So there's two drugs that are FDA approved. I've got some slides here, so they'll be in your notes. The bottom line, again, two different medications, and what they both do is they slow the progression. Neither one of them stops progression. Neither one of them reverses GA. They slow it down. So the way I describe it to my patients is they buy time. So whether it's the drug that slows it down by about 20% or by about 30%, they both slow down the progression, but it will continue to get worse anyways. Again, these slides are in the notes, so you don't need to write this down. I'm kind of zooming through these because you'll have access to them. By the way, patients know about these treatments because there's TV commercials about them. So I've had more than just a few patients come in and ask me about geographic atrophy, whether they saw the commercial with the really cool 60s era Mustang, the commercial with the weird tripped out senior citizens painting animals on their faces, or they saw the Fonz talking about macular degeneration. All right. That's what I have to say about AMD, about 40 minutes of AMD. Any comments or questions? I'll pause for just a second, take a sip of drink, and see if there's any questions on that section before I move on.
So there is a question. I'll let you ponder it because I'm going to make a comment about the smoking part.
Yeah.
The question is, can you comment on peptide 157 and also a Runalite device bought online for AMD? So peptide 157 and the Runalite for AMD. With that being said, I was always, we always know smoking is bad. So I was digging around and talking to some of the naturopathic docs, and probably the best answer that I got and is out there is that your body triages. Remember, like when you go to a war, that's where the triage came from. When a war or a battle happened, people, the medical team ran out onto the field and they triaged one of three things: the soldier's dead, um, they're bleeding out, let's give some attention, or hey, you just got a paper cut or whatever, go back to the camp. So one of three things, and that's what they do in hospitals. They triage. Your body does the same thing. So when you have all these antioxidants and all these fruits and vegetables and all these different things that we're eating, when you smoke a cigarette, which has been proven to have over 2,000, and vaping is just as bad, that's usually the next question. So, vaping, smoking's got all these toxins. Your body cannot store them for protection. It's got to take care of all these toxins. So, that's why smoking is one of the reasons why smoking is bad, is that it just depletes, doesn't give your body. So, Jeff, as you say, we always travel. So, I watch people when they eat, you're at the Marriott, they have this great breakfast. Maybe they go and have that one or two glasses of juice. Then they walk outside and then they have that cigarette, and it just depletes some of those fruits and berries maybe they just ate that were whole because the body can't store them and has to take care of those toxins. So,
So the question, peptide 157. So I have to admit I haven't heard of it. So while Greg was talking, I looked it up here. So it looks like it's a peptide derived from human gastric juice and marketed for its healing properties. So I'm gonna have to look into it more. I don't know anything about it.
yeah,
Uh,
peptides are huge in functional medicine. And if you think about it, like the GLP is a peptide, it's a
yeah.
hormone, it's a peptide. There's all kinds of peptides that are out there. This is one that's more of a growth hormone. I really haven't heard it used for macular degeneration. It's usually used for like muscle repair, and it's illegal. It's one, it's against, it cannot be used in kind of the athletic realm. It's one of the kind of the blood doping ones, but
Huh.
peptides are big. It's amino acids and so on and so forth.
And
The
what was
Arena
this? That?
light is a
Oh,
biomodulation
yeah.
light. It's red light. It stimulates mitochondria. I mean, it's
Yeah, the thing about the different lighting systems you can buy online or for different places is it is not as simple as it's a red light. I mean, it's a red light, exactly like what Greg just said, but there's lots of other qualities about the light that are important. What's the exact wavelength? What's the intensity? What's called stroke? So how deep is it going into tissue? Where is it actually hitting? I was talking to someone from a company today whose device emits light that its stroke or where it hits is about 22 millimeters from the source, which puts it theoretically at the junction between photoreceptors and RPE, which is where the inflammation happens. So there's a lot more to it than someone going online and buying a red light. If you ask me, is it going to harm somebody? No. Is it going to help them? I don't know. I couldn't say with any um, confidence that it would be of any benefit.
are you supplying curcumin in your office?
So I would say yes and no. So I actually use a dry eye supplement that has curcumin in it. And it also has lutein and zeaxanthin. So as it turns out, I think it's actually a really good product for dry eye or for macular degeneration.
Very
What's
good.
your answer to that one, Greg?
Yeah, I mean, I don't sell it. I don't use it separately. I use it in combination.
Yeah,
I'm more, I think, Jeff, as you learned over the years, I'm not more of an isolate guy.
right.
I'm more of a comprehensive guy. You know,
Totally
curcumin,
agree.
astaxanthin, polyphe, all the, it's everything. Then, if you want to target with a little bit of lutein and zeaxanthin to kind of give that punch to the macula, go ahead. And I think it really comes out of that. I think it was Centrum Silver that they used in both AREDS 1 and AREDS
Yeah.
2.
Yep.
And if you go look at the frequently asked questions, I mean, 9 out of 10 were taking a multivitamin.
Yeah.
So
Yeah.
they should,
Yep.
so comprehensive. So,
That is true.
um, what is the relationship between sleep apnea and AMD?
Ah, so that's actually an important one. So there is a correlation between sleep apnea and developing AMD, in particular, geographic atrophy. There's also been some studies that show that if you sleep too much, that you're more likely to develop macular degeneration. So sleep apnea is bad for a lot of things, right? We know that it has negative implications for AMD, for diabetes, for glaucoma. Um, so there's something called the easy sleep apnea test. And so a way that anyone can test themselves and it kind of as a screener for sleep apnea. You take your hands, can you put them around your neck and touch? If there's more than about an inch, because you can't touch, then it is very highly likely that you have sleep apnea. If you can actually touch, it's very highly unlikely that you have sleep apnea. So that's just kind of an interesting little side note, I think, if we're talking about sleep apnea. I don't test for it. I can look, or I could have someone put their hands around um, to try to gauge their risk of sleep apnea.
Jeff, you just gave me a little bit of an out. There's about, 2 times a year when I'm at the front desk having my hands around someone's neck. Now I can just say I'm checking for sleep apnea.
There you go. There you go. I feel your pain. I feel your pain.
that you just gave me that out. So,
Yeah, there you go.
uh,
You're testing
no, I
them.
like those different, those are all kind of quick, right? Like you can tell if you're insulin resistant by taking the height in inches and then find this your around your, not your waist, but around where between your breast and your belt, it should be less than half. If it is, you're probably insulin resistant. Triglycerides over HDLs, should be less than two. So these little quick things always kind of just help get to the root cause. So yeah, glad someone brought up about that sleep apnea.
Yeah.
That was a good pearl there. I like that. One more question here. Do
Yeah.
you discuss the increased risk of wet AMD with geographic atrophy treatment options? This doc feels it's under discussed.
Yeah, it's a real issue. So depending on which of the GA medications, they both absolutely increase the risk of wet macular degeneration. The actual percentage is different between the two, whether it's a 12% increase or up to a 4 times increase. But and Greg heard me. I was doing a talk this weekend with a retina specialist, and this topic came up. And the retina specialist response was, if you have GA that you don't treat, it will get worse. You will lose vision. If you get treated for your GA and you develop wet macular degeneration, we have good treatments for that. And if you're getting treated, you're going to be seen more often. We'll see it quickly, and you'll do fine from the wet part. And I thought that was kind of an interesting take on it, and I think that's true. Do nothing about GA, always gets worse. Develop wet AMD, if you treat it, usually people do okay. So yeah, I do think it needs to be discussed.
Yeah, let me just put a little twist or add to that
Yeah.
is that, I want to go back and just think about what those two medications are doing, Izervay and Synfovre, is that they're monkeying with the immune system. I always say it in my biologic lectures, whether it's for Tepezza or whether it's for wet macular degeneration or whether it's for GCA and you're using, tocilizumab that's out there, Actemra, anytime or anytime you're monkeying, whether it's a steroid, oil steroid, when you're monkeying with the immune system doesn't like it. COVID and the COVID vaccine, when you monkey with the immune system will kick back. So there's no surprise that there's an increased risk because it's a complement 3, complement 5 inhibitor. You're monkeying with the immune system. So yes, it puts you at risk for the wet macular degeneration. But I agree with that ophthalmologist is that, which do you want? Do you want to just lose vision over time or do you want to take it, which has this, whatever the percentage are, 6%, 8% risk, which we're going to monitor for, and that could be treated. So yes, it needs to be discussed. I don't think it needs to be discussed in a super negative way. I think it's,
Right.
hey, you got an autoimmune condition, whether it's geographic atrophy, you're going to monkey with it, it's going to kick back.
Yep. Great point. So speaking of autoimmune, sometimes diabetes is an autoimmune condition. So let's start with some myths and misperceptions. So myth, A1C drives diabetic retinopathy. Actually, as it turns out, A1C only controls a relatively small percentage of your risk for diabetic retinopathy. It is a misperception that A1C is the most important number for people with diabetes. Time in range, as measured by a continuous glucose monitor, as it turns out, is far more important than A1C. NPDR only gets worse. That's a myth because it can actually be improved with treatment to the eyes. Posterior pole NPDR is all that matters. It's a misperception because, as it turns out, peripheral NPDR may be as or more important than what you see in the posterior pole. And I think this is a really important misperception. We take care of eyes. Nope, we take care of people, and systemic health affects eye health. And I think Greg would agree with me that if we ignore the systemic aspects of the eye conditions that we see, and we just take care of the eye condition, we're barely, putting a patch, putting a Band-Aid over something that needs stitches. We're not fixing it. We're not taking care of it. So I think, as optometrists, having a bit more holistic of a view is something that's really important for us and our patients. Part of that holistic view is really just how you, not just how you treat, but how you talk to and talk with your patients. So I think that calling someone a diabetic is not a good idea. Few people want to be known as or even by their health status. For example, if someone had AMD, would you ever call them a macular degenerate? No, because that sounds silly. Or you wouldn't say that somebody's cancerous. It's someone that has macular degeneration, it's someone that has cancer. People with diabetes are just that, somebody has diabetes. It's a person living with diabetes. So I do my best never to call somebody a diabetic. Don't substitute a part of a person for the whole person. All right, so I'm going to talk about some different diabetes related facts, and you might say, Jeff, isn't that what the primary care or the endocrinologist is for? Can't we assume that they talk to the patients about these general systemic things about diabetes? You can assume that, but I think we all know what happens when you assume. So this was a paper that was published just 8 years ago. And it was a survey of about 150 primary care physicians that were attending a retreat for academic affiliated multi-specialty practices. So these are academics. And when you ask these over 150 academics, only 6% knew the risk factors to prompt a screening for prediabetes. Only 17% knew if labs were done, what findings constituted prediabetes, and only 11% knew what you're supposed to do if somebody has prediabetes. Crazy, right? So, what are the lab parameters so that you can be ahead of the vast majority of academic-based primary care physicians? So, depending on the test, whether you're doing a fasting plasma glucose A1C or a 2-hour OGTT, oral glucose tolerance test, here's the numbers. So, A1C less than 5.7 is normal. 5.7 up to 6.5 is prediabetes. Above 6.5 is diabetes. To the left, you see the numbers for fasting blood glucose. Under 100 is normal. 100 to 125 is prediabetes. 126 and above is diabetes. So, by the way, if you just know this, you know more than the average primary care physician. I mentioned peripheral disease, and peripheral disease is important. Having more peripheral diabetic retinopathy than you have in the posterior pole confers greater risk of worsening, and it confers a almost 5 times risk of developing almost 5 times risk of developing proliferative diabetic retinopathy in 4 years. That's significant. The other issue is if you don't look at someone's peripheral retina when you grade their NPDR, about 10% of the time you will underdiagnose, you will underclassify. Why is that important? Well, the follow-up for someone with diabetic retinopathy depends on severity. If you undergrade the severity, you won't watch them closely enough. What happens if you don't watch them closely enough? You may not catch it when they convert to PDR, proliferative diabetic retinopathy, and need treatment. So examining the entirety of the retina, whether it's through clinical exam, ultra wide field photography, or whatever you're doing, is really important. A1C. So I mentioned this earlier. Is it the best predictor of diabetic retinopathy? It's not. It probably accounts for only 6 to 11% of someone's diabetic retinopathy risk. Just when we're getting used to asking people about their A1C, and just when people, at least sometimes, know their A1C, as it turns out, that is not the most important number. And so I want to introduce two terms to you that I think are vitally important for you to know and to bring up to every patient of yours that has diabetes: continuous glucose monitor, or CGM, and time in range, or TIR. Polling question for you. Which of the following is a good time in range for somebody using a continuous glucose monitor? So this is kind of a pre-test because I haven't gone over it yet. So which of the following is a good time in range? 25%, 120, 75%, or 6.0? Which one is a good time in range?
Okay.
So,
Polling question is open. I see people responding. When I looked back a little earlier, Jeff, I didn't see any questions other than the
okay,
last AMD, but let me
great.
check here real quick. Nope, we are caught up. So,
So, hopefully we're all seeing more and more patients that have a continuous glucose monitor as more insurances pay for them, as they become more affordable and readily available. Because it's probably the best thing that someone can do in order to gain control of their diabetes. You can't control something if you don't know what it is, right? With a lack of information, you can't answer questions. So, how are you answering questions as far as your treatment? What do I need to do? How am I doing? If you don't have numbers to tell you how you're doing.
So, well, I think, like always, the audience is, the OEC audience is not letting us down. I'd always do them as phone a friend or ask a friend. So I see a nice trend here, and I'll display the answers. Is that 20% went with 25%. So the A 25% was 20%. We have 120 as being seven responses, or no, sorry, 11%. And then we have 57% going with C, 75%. And then six was 14. So your winner is 75%.
Awesome. And that's the right answer. So, in time and range is what percentage of the day is what percentage of time of the day is your blood glucose within a specified range? And I'll go over that in just a minute what that range is. So the higher the number, the better in a percent. So 75% is actually outstanding. The 120 was just trying to catch someone if, someone's average blood glucose is 120, and 6.0 is kind of referring to, well, if your A1C is 6.0. But again, with a continuous glucose monitor for time and range, what you're looking for is a percent. So great. Everyone, not everyone, but the majority had the right answer before we even talked about it. Number one path to diabetes prevention, lifestyle changes. And it's interesting. It's, what's good for you if you want to prevent AMD? What's good for you if you want to prevent diabetes? What's good for you if you want to prevent heart disease? Fill in the blank, all of them, it's the same. And the reason why I think that's important is because some of us may not feel comfortable talking about these things with patients. I hear doctors say, well, look, I'm an eye doctor. I don't talk about smoking. I don't talk about sleep. I don't talk about bariatric surgery. Well, but that affects our patients' health. That affects their eye health. And if we want to do the best by our patients, these are really things that we need to be in tune to. We don't need to have all the details, but I think we need to at least bring them up. And what's convenient for us is it's not like we're going to say something, hey, you ought to consider, that someone's going to hear and say, well, that sounds weird. No, they've heard it 1,000 times from every other doctor that they go to. We have complementary messaging. And I think that's really, really important.
Jeff, let me
Um,
give you an example here of what I've done 3 times so far this year. I've had a true type 2 diabetic come in, patient with diabetes.
there you go.
And so that's how I say to my staff. I say, look, they're not diabetic, they're patients with diabetes. It's Greg with diabetes, it's Jeff with diabetes. These are patients with diabetes, they're not a diabetic. But I had two patients come in that were type 2, and they're seeing PAs and so on and so forth. And 3 times this year in 2025, I have stopped a patient that was type 2 from taking insulin, because there is a total difference between type 1, where the pancreas and the alpha and beta cells just aren't can't produce insulin, so they need insulin. But a true type 2 diabetic patient with diabetes got there by being insulin resistance, hyperinsulinemia. And I always say to them, I said, your doctor just said, here's a glass of wine, it's made of grapes and white or red, but you're an alcoholic, but it's okay. Like, no, it's not okay to give an alcoholic a cocktail, no matter what type it is. Why are we giving insulin to someone with type 2? Called up the PA, spoke with the primary care doc, spoke with the patient, and got them off. So there we go. Now I'm an eye doctor, and I help this patient out treat their type 2 diabetes and insulin resistance. So we have to advocate.
Yeah, no, I think it's a great point because just because someone's on medication for diabetes doesn't mean they're being appropriately treated for their diabetes. As it turns out, there's medications that most people shouldn't be on, but a lot of people are just because they're cheap. That doesn't mean they work well. It doesn't mean they're not causing harm. It just means they're cheap. And so, to your point, Greg, I think we absolutely play a part in taking care of these patients, not just how's your vision. What I tell people all the time, especially people with diabetes, is, when we check your vision, that tells us what your vision is today. But how your diabetes is doing is how your vision will be doing tomorrow. And if your diabetes isn't appropriately treated, then it's way more likely that tomorrow you're gonna have a problem with your vision. And I try to explain it like that. Prediabetes is a pretty common condition. There's about 90 million Americans with prediabetes. And you know what the best treatment is? It's not metformin. It's intensive lifestyle intervention. It's, at least from this study, 150 minutes of physical activity per week, 30 minutes, 5 days a week. Why do I point this out? Because I saw someone just today that has prediabetes and is on metformin. And I asked, do you take the metformin because you have diabetes? No, I have prediabetes. Did your doctor talk to you about the importance of diet and exercise? No, they told me to take this pill. Wrong answer. So we had a brief conversation about it. So to Greg's point, you ask enough questions, this becomes a pretty common thing. And by the
Muscle is the
way,
best endocrine gland. Fat is the worst.
yeah, muscle is great. So by the way, this study that I just mentioned, even 26 years out, there's data 26 years out from the study that still shows the most important thing you can do is to exercise and to take care of yourself. It's not starting metformin. So now I think the real question is going to be, 5, 10 years from now, are we going to be saying it's this, or is it one of the GLP drugs, or is it something else? I don't know. But for now, lifestyle intervention is the most important thing for people with prediabetes. What should we be eating? Eat food, not too much, mostly plants. Sounds good. The problem is what we do is eat food-like products far too much, mostly refined carbohydrates with low nutrient density, trans fats, and devoid of fiber. So where diet should be the main source, where diet should be food should be our medicine. For most people, food is our poison. Now, some other food for thought, by the way, because we think of diabetes as being a disease of prohibitions. Chocolate can be good for you in moderation. So eating a whole box of chocolates is never good. Chocolate in moderation can have beneficial effects cardiovascularly or actually even from a blood glucose perspective in moderation. There's been studies that show that on this slide, used to have alcohol because there are studies that show that alcohol moderation can be beneficial. Now, the issue with that is really the prevailing science more recently is that no amount of alcohol is good for you because of it being carcinogenic. I put fast food on here because about a third of Americans eat fast food on a daily basis, and it is basically impossible to make a positive case for fast food. So fast food, not good. Chocolate can be. So I think that's important. Does good control of your diabetes eliminate the risk of severe diabetic retinopathy? It does not. Some people will do poorly despite good control. Let's go back to continuous glucose monitor. So here we have one that is on somebody's abdomen. The most common one is the freestyle that you see on someone's arm. Interestingly, if somebody starts wearing a continuous glucose monitor on average, it lowers someone's A1C by as much as going on an oral medication, which is pretty amazing. If you know how you're doing, you're able to change and affect change and do better. So on the bottom left here, this is someone on their phone. They're seeing that their CGM is telling them their blood sugar is 71 and dropping like a rock. So that means it's time to take in some sugar before you become severely hypoglycemic. Here we see someone that's kind of going up and down, but right now they're at 202 and trending up. Maybe time to go outside and take a walk. If that's someone that's on insulin, probably time to take some more insulin. But it can guide you as to what's going on. Whoop, my watch is talking to me. So here's why time and range is so important. And I can explain it through simple math. So the simple math here is what's the average of 250 plus 50 plus 250 plus 50? Average is 150. Next one, what's the average of 150 plus 150 plus 150? Well, actually, let me replace that by 160 plus 160 plus 160. That average is 160. So both of these either have the same average or the second one, the average number is higher. However, which one of these two people, if those are their blood glucose readings, is going to do better? It's going to be the one with stability. Where damage occurs is at highs and lows. Stability is what's most important. Stable and slightly high is way better than a lower average because of highs and extreme lows. The highs and lows are where the problems happen. That's why time and range is so important. Generally, the generally accepted range is 70 to 180 milligrams per deciliter. You might say, well, 180 sounds really high. Well, what we know is it's when you get above that to when you start really having problems. If you can keep it within that range, people will do really well. What we know is that for every 10% decrease in your time in range, so doing a little bit worse, your risk of developing or worsening of retinopathy goes up by 64%. So I reverse engineer that and I tell people if you can do just 10% better, you can decrease the risk by half. I fudge the numbers a little bit. The key number is 70%. The goal for your time and range, so between 70 and 180, should be 70% of the day. If your time and range is at or better than 70%, the risk of you developing or having progression of diabetic retinopathy is 5%, really low. As it turns out, that's not just for diabetic retinopathy, that's for kidney disease, it's for cardiovascular disease, it's for many other things. 70% is kind of the magic number. So I bring that up with my patients all the time. Do you use a monitor? Are you at 70%? I have them show me on their phone. If they can't find it on the app, I show it to them. When I ask patients with a CGM, what's your time and range? Kind of like what's your A1C, and you get, huh? Well, if I ask someone what's your time and range, if they say, what's that? I say, that's the only reason why you wear this thing that's attached to you. You need to know it. Let's look at it. And I have patients that come in all the time and tell me, hey, you're the one that explained this to me. I didn't even know what that was before you told me. Should they know it? Yeah. Do they all know it? No. It's pretty quick and easy to be able to tell them. Something else I think it's really important to realize with diabetes and diabetic retinopathy, people with diabetes, and even more so with diabetic retinopathy, are more likely to have depression. There's almost 4 times more depression with diabetic retinopathy versus those that don't. Up to 90% of people with diabetic retinopathy have some sort of mood disturbance. Severe DR and DME and vision loss is significantly associated with poor psychosocial outcomes, which could be avoided with more timely identification and treatment of the diabetic retinopathy. And the reason this is important is because what we do as optometrists is we provide quality of life. And oftentimes, this fear of loss of function leads to a dramatic decrease in people's quality of life. And depression generally gets worse with worse diabetic retinopathy. It's not often that I talk to people about the benefits of seeing a therapist or a psychologist or therapy, but it comes up because, as Greg mentioned earlier, our job is to advocate for our patients. And if we're truly advocating for our patients, it's not just advocating for a pair of glasses when they need it. It's advocating for what's in their best interest. I just show this to show you there's different scales for measuring level of diabetic retinopathy. In clinic, we use the top one, and clinical trials use the second and third because they have far more levels, so it's easier to tell subtle changes. So I'm going to skip over a couple slides because of time. But what these slides, and again, because you'll have these slides, what the last couple slides are talking about is that if someone has diabetic retinopathy and it's non-proliferative, sometimes that can and should get treated. Studies have shown that if you treat non-proliferative diabetic retinopathy, if it's what's called moderately severe, the majority of patients improve fairly markedly. And if you wait too long, if you wait for it to become proliferative, it's kind of too late. Then what you're doing is you're just trying to prevent a disaster. You're not trying to reverse course and allow people to do really well. So again, timely examination, identification, and referral for treatment is super important. So knowing how often to see people with diabetic retinopathy is really important. If someone has diabetes and they have any diabetic retinopathy, we need to decide how often we see them. And if someone has diabetic retinopathy, at the very least, it's once a year. But many of those patients, I'm seeing them twice a year, sometimes more. And I'm gauging that on how's your overall blood glucose control? How long have you had diabetes? I do ERG, and what does the ERG tell me? Because that's an excellent functional measurement. It's far more predictive than OCT or really virtually anything else as far as determining who's likely to progress and get worse. So knowing how often to see patients, explaining to them why you're doing that, and then executing is vitally important. Okay, so a couple takeaways from diabetes. There's more to good diabetic eye care than just what's your A1C and you don't have any NPDR. I mean, that's something, but that's not being very proactive. The more active a role you take, the likely better your patient will do. And when I say this, and I think I've made it pretty clear, it's both from an ocular perspective and a whole body perspective. If the body's not doing well, sooner or later the eyes catch up. That's really important. I think it's a misperception that we take care of eyes. The reality is we take care of people. And I think that has to always be part of the way that we think, that we're taking care of people, not just eyes. If you take care of eyes, you can be successful today. But if you take care of people, then you and they are much more likely to be successful longer term. All right, polling question. How many patients with diabetes do you see in an average clinic day? So on the average day in clinic, so call it 9 to 5, 8 to 5, whatever it is. On average, how many people with diabetes do you see? Is it A, none, B, 1 to 3, C, 4 to 6, D, more than 6? I guess this somewhat depends on how many patients you see in a day, right? If you see 12 patients a day, 6 would be an awful lot. If you see, 35, 40 people in a day, 6 may not seem like so many. As it turns out, there's about 30-ish to 35 million Americans with diabetes. So just looking at the numbers, we're all going to see some. So, Greg, do we have the polling question up?
Polling questions up,
All
answers are
right.
rolling in. I didn't see any questions so far for diabetes. The last one was about geographic atrophy. Uh, I think I don't. That's let me write a
This is
message.
average clinic day. Some days that's all I see, and some days I may not see anybody with diabetes. But what's the average day?
I just wanted to say hello to the group just to make sure it was loaded properly, and it was. I wasn't missing any questions. All right.
Perfect.
This is actually kind of, I don't know if I want to use the word funny, but funny in quotes. I wonder if we go back, and I understand diagnostics were different, but when we were a healthier society, I wonder if this would have shifted. I'm going to display. Sadly, Mark, sadly, Jeff, that um, that zero people, um, there's none, where A is 0%,
Yep.
none. So that's just, 1 to 3 is the winner at 60%, and then 4 to 6 is 32. And then we have some people that maybe on a higher disease area that are seeing 8% or seeing 6 or more. So the winner is 1 to 3, but there's zero at none,
Yeah.
0%.
Yeah, that does not surprise me. Depending on where you live, the numbers can vary wildly, depending on state and even county you live in. I'll tell you, for me, I generally see somewhere around 20 patients in a half day, and I probably have 3 or 4 patients every half day that have diabetes. So I'm probably 6 or 7, but that's out of 40. And so if you look percentage wise, that's fairly close to the the average American population. So yeah, sad, but it's practical, right? And that's what I said I wanted to talk about, things that were practical. All right, so I'm going to move on to the next topic. Myths and misperceptions about peripheral retina. Myth, PVDs are benign. They usually are, but they can't be treated that way because some PVDs aren't just a PVD. There could be a retinal break. There could be retinal detachment. So we need to treat it, treat/examine accordingly. Misperception, VMA, vitreomacular adhesion, and vitreomacular traction are the same and need to be referred. Nope, they're dramatically different and they only need to be monitored because even if you refer them, ain't nothing going to be done. All right. Myth. All peripheral retinal changes need to be referred. No. Lattice, atrophic holes, and degenerations only need to be followed after patients are educated. And the reason for that is the vast majority of these peripheral retinal changes are not going to get treated. So either you can identify and educate, or you can send someone to a retina specialist where they're going to wait forever, and then they'll spend way less time and do less education. They'll come back to you with even more questions than before you sent them. So if you're comfortable in your peripheral retinal examination or imaging abilities, then these are patients that most oftentimes can be kept in your office. All right, so let's talk PVD. When a person calls into your office with symptoms of a PVD, when does that person get seen? So what's covered here should say, when does a person calling in with symptoms of a PVD get seen in your office? I think this is super, super important. The answer is not what you say. The answer is it depends on what the person answering the phone says. And so tomorrow, ask your staff, hey, someone calls in and they have a new floater. When do we see them? And, as Greg mentioned, I'm in an MDOD practice. We have 11 providers. We have about 40 staff. We have probably six different people that answer the phone. And every once in a while, I have someone that comes in, it's a new PVD that they called in 3 weeks ago about, but they were told we didn't have any openings for an exam. Wrong answer. I need to look on the schedule, see who scheduled that patient, and educate them that no, when people call in and it's new floaters or flashes, we see them today or tomorrow. That's the standard. We don't have them wait 3 or 4 weeks till there's a full exam slot. We get them worked in. So the answer is not what you say, it's what the people that are picking up the phone say. When you examine a patient, what is your standard of care for someone with a PVD? So, number one, I hope everyone's dilating. If it's someone that's coming in with PVD-like symptoms, I'm dilating both eyes always because they may think it's the right eye, but it may be the left. I'm dilating with both tropicamide and phenylephrine. I'm doing a BIO exam with scleral depression, and then I'm looking at the slit lamp. And then one of the things I'm looking at the slit lamp is whether there's any pigment in the anterior vitreous or Schaefer sign. When do you have them follow up? Well, if it's floaters only and it's new onset, I have them back in a month. If they have flashes, that means they're still pulling. I have them back sooner, usually a week or two, and hope that the flashes are gone. Because if not, I'm going to see them back again in a week or two because they're still at great risk of developing a retinal break. They're still pulling. Why do I see people back in a month? Because if they don't have a break today, that's great. But a reasonable percentage of people, if they come in with a symptomatic PVD, ultimately develop a retinal break. And if it's going to happen, it generally happens within the first month or so. So, new onset, I have them come back in a month to 6 weeks. If it's been there for 3 months, I don't need to have them back. I don't need to follow up because it's already been there long enough that they're, for the most part, out of the woods. It still requires some education that, if you start noticing more floaters, new flashes, a veil or curtain over part of your vision, let us know. We need to see you right away. What is a floaterectomy? It is a vitrectomy to get rid of floaters. So here we just see a video of a small gauge instrument vitrectomy that I'm just showing because it's pretty cool when people have vitrectomies done. They have 3 holes poked in their eye. They have the vitreous sucked out, gas or I guess potentially oil, but generally gas put back in the eye, and those little ports pulled out and self-heal, and it's quick and easy for patients. It looks gruesome, but people do really well. So you can actually have a vitrectomy for floaters. Some retina specialists are very aggressive with this. That people have had floaters for 6 months. It's a little bit of a bother. They do a vitrectomy. I would tell you that I'm a little bit I'm a little bit more conservative with that as far as who I refer. The retina specialist that I generally use is also a bit more conservative. When I asked him about this, his response was, I generally don't do surgery for floaters except for when one of my partners does a vitrectomy and then it goes bad, and then I have to fix what happens after they did the vitrectomy. So again, depending on who the retina specialist that you use, you might hear different answers. But generally, it's if someone has floaters that are debilitating, then it's possible that they'll perform a vitrectomy for them. Another thing that people could have done is a laser floaterectomy or YAG vitreolysis. And we see an image of that here, some with a pretty distinct Weiss ring, and they're having a YAG vitreolysis done where just shooting a YAG laser at that Weiss ring, you see you kind of blew it open. It's kind of like playing asteroids, where you take a big asteroid, you blow it into a bunch of little ones and hope that some actually disappear. Um, there's been studies that, and this is the one I'm quoting here, is a study that had a little over 50 people in it with a Weiss ring, and about half had symptom improvement after laser versus only 9% without. About half had total improvement of symptoms, where zero had total improvement without. And that's based on the NEI Visual Function Questionnaire. Um, it appears to be pretty safe. So again, about half the time it works when patients are properly selected. If there's already a bunch of little floaters or a giant floater that's very anterior or very posterior, not good candidates. So it's Weiss ring kind of in the middle of the vitreous, too close to the retina, then there's too much risk that when they're firing the YAG, they actually burn the retina. If it's too close to the lens, then the risk is too much that you're actually going to hit the lens and create cataract or pit and IOL. So very careful patient selection. Another potential option for people with floaters are vitamins. There's a vitamin formulation that was tested in people with floaters. What we need to realize is when we say vitreous, it's kind of like when we say tears. Our tears aren't made out of one or two or three proteins. It's hundreds, if not thousands. And our vitreous is the same way. It's made of hundreds of constituents. And so it's possible that through supplementation that we can augment the constituents in our vitreous to actually be able to improve floaters. So QR code here to the actual study, but a study that showed that about 2/3 of patients taking a specific supplement had some improvement in their visual comfort. So you can see here the different metrics that were actually measured. They found that it took a period of 3 to 6 months to achieve this. I actually had a patient come in today that said, I've got floaters, and my daughter was taking a vitamin for floaters. I tried it, and it didn't help. I said, well, how many did you try? She said, well, I took one. I said, well, there was no chance for it to help. If you want to try it, then we need to give it months, not a day. So expectations, just like in everything else, are really important. Retinal tears. So this is why, by the way, it's important to have follow-up on your PVD patients, because if someone comes in with a symptomatic PVD, 15% study shown will actually develop a retinal break. That's pretty high. That's 1 in 7. I must be missing a lot of these because I don't see very many. And so, by the way, what do you do about a symptomatic tear? Well, we refer them for treatment, because if we don't refer them, then the risk of that developing into a retinal detachment is really high. So symptomatic tears require referral for treatment. And that's not a, hey, can you see this patient sometime in the next 3 months? Depending on where it is, that kind of hedges the urgency, but it's someone that you want probably seen in the next few days or maybe week. We're talking days, not months. What's the treatment for retinal tear? Well, symptomatic tears require treatment. Generally, it's laser. Here's someone with before and after. This is actually right after. So we see the tear over here. Here we see the laser barrier right after treatment because there's no pigment yet. Give it a little bit of time, and then you're going to have a bunch of pigment. The pigment that forms there is basically a spot weld. And so you're tacking down the retina. But again, no pigment there because it's all brand new. So why do we treat symptomatic breaks? Because if you don't, about 50% will develop an RD. By the way, even when you do, 5% will develop an RD. So once someone's had their symptomatic break treated, they're not 100% out of the woods. They need to understand that they're still at some risk. The importance of just routine follow-up and just being aware of any visual symptoms, flashes, or floaters. This one I just thought was a cool image. This is someone that did develop a retinal detachment and had a scleral buckle procedure done. Normally, when we look at the retina, we see, if we're looking with the lens, we just see quadrants, we just see little pieces. So here's an ultra wide field image, and you can see the scleral buckle that goes all the way around. Imagine, so I sometimes have optometry students. Imagine if an optometry student is looking at this patient, looking in at their eye, and had never seen someone status post scleral buckle. They're going to look in at this and say, holy cow, I thought this person had their RD fixed. They look terrible. It's detaching all the way around. No, that's the buckle compressing in. And it's because of that compression that it forces the retina back down. That's a good thing. This is a very normal looking post-op from a scleral buckle. What's this? This is somebody that actually had a vitrectomy for a retinal detachment. And what we're looking at here is their gas bubble. And so this is the gas bubble that's still remaining in their eye. It's probably about a 40% gas fill. You can almost see they have a second optic nerve here, right? No, it's just a reflection of their one optic nerve. What's important to know about this is as long as somebody still has gas in the eye, they're not going to see, or they're not going to see well until that gas is essentially gone. The other thing is if someone still has any gas in the eye, they can't fly because of the compression in an airplane, that gas expands. And if there's enough gas and it expands enough, you can figure out what happens to that eye. That's like taking a basketball and pumping it up and then pumping it up more. Not good. Lattice degeneration. Lattice degeneration is an optometric condition that does not need to be treated. There's no treatment needed if it's asymptomatic. There's no definitive proof to any benefit to prophylactic laser treatment. If somebody has lattice, the likelihood of developing an RD is very, very low. As it turns out, 89% of RDs in people that have lattice degeneration, the RD, the tear, occurs in an area other than the lattice. So if you treat the lattice, you're not treating where the detachment would have happened. So basically, the only way to prevent that detachment, if you believe in doing laser to prevent it, is basically do PRP, do laser everywhere, so that you laser the area where it would have happened. That doesn't sound like a good idea to anybody. So prophylactic laser really does not prevent a tear or an RD, even in fellow eyes. If so, there's really not a good case for someone having laser done if they have lattice. Again, because you'd have to do a whole lot of treatment to get lucky and get the area where the detachment would have happened. And the myths and misperceptions, I mentioned vitreomacular adhesion. So the VAST study was a study of VMA, vitreomacular adhesion, and VMT, vitreomacular traction, primarily done by optometric colleagues. So here's a case of a patient that came in, initial visit, new floaters in the right eye. And in the right eye, we see the vitreous face here as detached. It had probably been pulling, by the way, and created a little deformation there. But in the left eye, we see what's called vitreomacular adhesion. The vitreous is adherent to the macula, but not pulling it up. So vitreomacular adhesion. Well, this is a new PVD. So let's see the person back in a month. Well, right eye looks actually better. We don't see that little deformation there underneath the fovea. In the left eye, though, we now have vitreomacular traction. The vitreous is adherent to the center of the macula. So it's causing a deformation and this little cyst here. Have the patient come back a month later. Now we see free-floating vitreous in the right eye, free-floating vitreous in the left eye, normal contour to the macula, no longer noticing any floaters, and vision is back to 20/20 in both eyes. So PVD, VMA, VMT, PVD in both eyes. Kind of a cool case. So this was the VAST study. led by a couple colleagues of ours, Julie Rodman and Diana Scheckman. And interesting, what they showed was they looked in all kinds of different clinics for, hey, what percentage of eyes have VMA and VMT? And when you look in adults, around 39% have vitreomacular adhesion, only 1% have vitreomacular traction. For every 1 year increase in age, there is a decrease in VMA and VMT. Why? Because the vitreous detaches. African Americans have a vastly decreased odds compared to Caucasian. A larger area of adhesion is more likely in younger patients and hyperopes. Vitreomacular adhesion is more likely in primary care versus secondary or tertiary care clinics. So it's more common, it's more likely to happen in your clinic than in the clinic of a retina specialist. I think that's relevant because it means this is something that you will see in your office. Now, by the way, a note on practice management and financials. If someone has vitreomacular adhesion, and according to this study, about 39% of adults, you now have a billable code for OCT. I get it, OCT doesn't reimburse a whole lot, but it's kind of nice when you can do good medicine and get paid something for doing it. I know we're nearing the end of our time, but I think I'll be able to get through these last few slides pretty quickly. Central serous. So, central serous is a condition related to type A personalities. Myth. Steroid use is the most relevant predisposing factor. Central serous needs to be referred immediately for treatment. No, there is no universally accepted or proven treatment. And another misperception is that central serous is common enough that I can diagnose it on clinical exam alone. I believe absolutely not. You have to have an OCT and or fluorescein angiogram to confirm that there's not choroidal neovascular membrane. Central serous generally gets better. Choroidal neovascular membrane gets worse. We need to know what it is. I could do 10 slides on this, but this is an optometric condition until it's not. Nothing is proven to be more efficacious than watchful waiting. There are articles talking about nonsteroidals, carbonic anhydrase inhibitors, photodynamic therapy, spironolactone, which is an aldosterone receptor agonist. There's really nothing that's shown to be much more beneficial than just waiting. The spironolactone, the evidence is a little better than the nonsteroidal CAIs and PDT, but in most cases, you're going to wait a month or two before you do anything. I mentioned it just a minute ago. Have to confirm the diagnosis. It can't just be, I look in, I think it's what it is. We need to confirm it, monitor, and refer if it worsens or if you're uncertain. If you're like, you know what? I don't know if that's central serous or if that's a choroidal neovascular membrane, then refer the patient. The worst thing you can do is sit on it and watch it, and a choroidal neovascular membrane goes downhill. All right, couple potpourri questions. A retinal artery occlusion is an ocular emergency. No, it is a general health emergency and needs to be treated accordingly. Plaquenil is very likely to cause maculopathy. No, it's actually quite low, as long as someone's been on it for less than 20 years. Misperception of choroidal nevus should evoke fear of conversion. Again, no, it's really unlikely, and there's different ways we can gauge the risk, but it's super unlikely. It's important to identify, image, monitor. Again, I could talk about each of these for 30 minutes, but we're running out of time, so I'll be very concise. Artery occlusions, we know about Hollenhorst plaques. We've known about them for over 50 years. And if we see them, it is a systemic health problem. Artery occlusions, they affect the eye, but they are a systemic health issue. Here's a patient that I had, and this is about 5 hours in. Actually, I had an ophthalmic artery occlusion, NLP in this eye. What you're seeing over here is actually pterygium retinopathy. She had a pterygium that made imaging very difficult. But this was a very, very sick patient. Her blood pressure was 260 over 150. I checked it 3 times. I called the ER. That's what they got. But she had an ophthalmic artery occlusion. What's important to realize is artery occlusions happen in sick people. Virtually everybody has something wrong that needs attention paid to it. They need an immediate referral to an emergency room that is a stroke center. Don't just send them to their doctor. Send them to an ER that handles people that have strokes. Critically important. You may only see one or two of these patients in your practice lifetime, but when you do, it's really important. Choroidal nevus, these are the 5 things to look for to help you gauge risk. If you don't see any of these 5, again, this will be in the notes that you can download, then the risk is exceedingly low. If you see all 5 of these, risk is pretty high. If it's something in between, that's when you need to decide whether you're going to refer to a retina specialist. So no factors. Um, it's actually lower than this. I'm not sure where we came up with the 3%, but if they have 2 or more factors, the risk is dramatically higher. That's my cutoff. This was updated in 2019 using ultrasound, but most of us don't use ultrasound, so we'll skip over that. Um, this was a field, excuse me, of a patient of mine that had Plaquenil toxicity, obviously pretty severe. First eye exam in a while. She'd been on Plaquenil, 400 milligrams for 13 years, noting that her vision is just kind of weird, but still good. Here's what she looked like fundoscopically. Nothing to see. Doesn't matter how hard you look. Here's what it looks like on fundus autofluorescence. You do see a little bit of a bright band around the macula. And here's what she looked like on OCT. Clearly not normal. I'd heard people talk about flying saucer sign, and now I think I see it. And if you get the Greg Brady reference there, congratulations. All right, Plaquenil toxicity. We'll skip over that. Last interactive question. We don't really need to, well, I don't know, Greg, do we need to do this question? I have 2 slides left.
We do not.
All right. So we won't really do this question except for me to point out myth. I don't do low vision, so my patients don't need it. Or low vision is so old school. Wrong and wrong. It is a vitally important aspect of eye care for people that need it. It's not just old-fashioned magnifiers. There are some super cool low vision solutions. By the way, the most common low vision solution in the world is your smartphone. Does lots of great stuff for your patients. But there's other really cool high-tech devices that allow people to function. And it's really important. Just because you don't do it doesn't mean patients don't need it. I'm going to bet, since we're all optometrists, none of you do cataract surgery, but you all have patients that need it and you refer out for it. So I think it's important to end a talk where we're talking about retinal pathology and mentioning low vision. And that if you have patients that need low vision assistance, find someone that provides it. Actually, when I got to the office today, I'm looking at my desk here. I put them up above. When I got to the office today, there was a big envelope waiting for us from a local practice that does a bunch of low vision. And I'm glad we have those flyers that I can hand out to patients. We'd requested more. If you don't do it, it doesn't mean your patients don't need it. So please pay attention to low vision. So conclusion is, well, you already had that at the beginning. So I don't really need to go over a conclusion, but hopefully you feel empowered to help your patients with posterior segment pathology. I talked a little bit about a lot of things, more in depth about the really common things, but sprinkled in a couple other things that hopefully you're taking away, that, the importance of us identifying, educating, and whether we do the treatment or send for the treatment to make sure that your patients get on that right road so that they can have better outcomes. Here's my email. So if you have any questions after we're done, feel free to shoot out an email. Greg, did we have any other questions?
We do, but I do want to make a comment. You mentioned, the high risk factors for those choroidal nevi and
Yeah.
nevus, and a lot of that work was done by, Dr. Jerry Shields, and
Right.
I guess in a celebration of life, just for the audience to know, is that Jerry Shields did pass away in June. I have it here, June 27th, 2025. So just out there for a celebration of life. He's passed away, but yeah, we're still talking about him and the work he's done that's out there. So we wouldn't be where we were with these ocular melanomas and treatments without his work and his wife's work. So,
Yep,
um,
absolutely.
and along with that, we do have one final question going back to the flashes and floaters. If it's a new onset with flashes, there is no hole, tear, or undilated exam. They come back and still have flashes, and there's still no hole, break, tear, undilated exam. How often are you seeing them back?
Yeah, so I'll generally do two follow-ups for the flashes. So if the first time they're having flashes, I'll generally have them back in a week or two. And if they come back and they're still seeing flashes, then I'll probably have them back again in 2 weeks. And then if they're still having flashes, that's when I kind of let it go. But for me, it's I'll have two follow-ups if they're still having flashes.
Yep, I agree. That's pretty much, the same thing. Make sure that it is retinal, make sure it's not maybe coming from
Right.
a medication and so on and so forth. So,
Yeah, I had a patient yesterday that was telling me about his flashes, and his flashings happen in a semicircle that kind of jagged lines. And after he has his flashes, they stop. He gets a bad headache. So his
mhm.
flashes are giving him a bad headache. I said, no, that's a migraine. And so to your point, Greg, I mean, it's interesting sometimes the things that come up. People come to us think they're having an eye problem. He's like, so my migraines? Is that because of my eyes? And I said, no, migraines are neurologic. It's not an eye problem, but you have a visual disturbance because of your neurologic issue that you have.
Very cool. So, as Jeff, before I wrap up here, I want the audience to know here that you're on your screen. If you look, chat, polls, clinical notes, survey, there's this little red dot. You can click on that survey. That survey is active, or you can just wait 6 minutes and get it via email. That's out there. Um, and with that said, it looks like all the questions. Greg, could you please elaborate on no insulin for type 2? It seems to, I see this a lot. Real quick, Mark out there with regarding that is that, most people are insulin resistant. High insulin is by basically because of carbs, fat, and protein don't spike insulin. So it's all these carbohydrates, it's all this juice that Jeff was talking about, just kind of creates the insulin. Even after fasting for 24 hours, the insulin levels are still high. So now your body's breaking down fat because insulin is high. It kind of stores it. So it's this whole insulin resistance. And then when insulin resistance can't, because of all the hyperinsulinemia, the patient can't keep up anymore. And now their sugars go up. Now they're diabetic when pre-diabetes or insulin resistance has been going on for a decade. And so the problem is that there's insulin and their insulin can't keep up, but the insulin creates all the metabolic diseases, right? That's the obesity, that's the dyslipidemia, that's the diabetes, it's the type 3 diabetes, which has nothing to do with glucose, has to do with insulin. That's your dementia and Alzheimer's that's out there. So that's your metabolic condition. So all those things are not solely related to insulin and hyperinsulinemia, but it's a significant cause. So the worst thing that you could do to a type 2 diabetic is give them more insulin when that was the cause of their type 2 diabetes. So
So Greg,
probably some,
the one caveat I would give to that is it's possible that someone has type 2 diabetes long enough that their beta cells die out and that they're no longer producing enough insulin. So I think you'd probably agree in someone like that, insulin could be appropriate. But to your point, the ones that are inappropriate are the much earlier in diabetes. You're just flooding them with something that's going to likely just make them worse.
yeah, that's a good clinical pearl, Jeff, because as always, we can never always say always and never, but
Right.
these three patients that came in, they were just kind of brand new. And, oh, I heard bad things about metformin. Okay, I'll put you on insulin. I'm like, oh my gosh,
You're right.
they heard they heard bad things about metformin, and now they just got the cause of what's causing their diabetes.
Right.
Um, so so that's the questions. I'm going to feed off of one of Thomas's comments here. And Jeff, you can open them up. I think you can see them if you go to the comment. Maybe you can't. I think you might be able to see them, but
I don't think so.
practical and well presented. And, that's what OEC likes is, Jeff is a fan favorite because, he is a clinician and that's what we like to have at Optometric Education Consultants in our webinars and in our live meetings. So, with that being said, you're getting your virtual round of applause. The thank yous are rolling in. This is Optometric Education Consultants National Webinar Series. This was Misperceptions in Posterior Segment Disease. This was a synchronous virtual course presented awesomely by Dr. Jeff Gerson. So, Jeff, thank you again for doing this for us.
Thank you, Greg, and thanks for everyone for spending your evening with us. I appreciate it.